Good evening, everybody. It's 6:34. We're going to make a start. I know people are trying to join, and maybe they will whilst we have our introductions. I wanted to say thank you for joining the 2021 first webinar of our fantastic series. We hope you'll continue to join us. We have some excellent programs ahead of us, starting with, of course, this one this evening. I'd like to say that as UKISCRS have become a charity at the end of 2020, we would like to continue to provide our digital education, and we now have a donate here link both on the summary email sent to you today and on the homepage of our website. Of course, we wouldn't have been able to provide the education to date without our amazing industry colleagues, all of whom, without exception, have supported us throughout this pandemic. And it is with their help, and now potentially yours, that we can continue to do so until we can meet in person. I would like to thank Tay UK, Hargstreit and Scope Eye Care for being our supporters today. As ever, we want to be interactive and for you to feel as involved as possible. And we'd like you to ask questions which will go directly to our moderator, Sarge Khan. However, please do use the Q&A tool in your bottom toolbar to do this and not the chat, because sometimes we miss questions and we don't want to do that. Before I hand you over to our new president, a very exciting Professor Satish Srinivasan, I'd like to tell you a short little bit about our chair this evening, Paul Ursell. Paul is one of the UK's leading cataract surgeons and has devoted his professional career to improving cataract surgery, making it safer and easier for patients. He has personally performed over 7,000 cataract procedures in a career spanning, I know you won't believe it to look at him, 25 whole years. He's developed a patient-friendly, no needle, no patch technique for cataracts, and that is something that is now taught across the NHS. It is without further ado, I'm going to hand over to our fabulous president, Professor Satish Srinivasan, and I hope you thoroughly enjoy this evening. We've got a great panel. Please ask your questions and we will do everything we can to make sure they get answered. Paul, before we hand over to you, Satish.
Thanks, Jill. Good evening, everybody. Happy 2021. I hope this year turns out to be better than its predecessor. It gives me great pleasure to welcome you all to this first series of webinars for this new year. We've got a stellar lineup of international speakers who all of them have earned a great reputation in their own regard, so none of them need great introductions. I hope you will enjoy it and look forward to it as much as I do. Without further ado, I'll pass it on to Paul Ursell to kick this off. Paul?
Thank you very much, Satish. Thank you, Jill, for that highly entertaining introduction. So we've got a lovely session tonight. There's lots of new formulae that have come out, and hopefully it will help us all to understand them better. Patient satisfaction after cataract surgery is very closely related to making sure you get the refractive outcome right, and using the right formula is key to that. So we've got three amazing speakers from all around the world. Just to illustrate, this is JCRS from this month, and we've got 3 articles out of the 15 were authored by the speakers we've got tonight. So they're not only are they the people who created the formulae, but they're also the people who are now educating us all in and doing research on them. So our first speaker is Professor Doug Koch, who is a professor in Houston, Texas. He's had an AAO Lifetime Achievement Award. He's been editor of the journal JCRS, and someone we all know very well. So I'm going to ask Doug to lead us off and give us our first talk tonight. Doug, over to you.
Thank you, Paul. I hope everyone can hear me well, and let me share my screen and we'll start here. My talk is about IOL calculations, and I want to talk about where we are in progress and limits in what we're doing with them. The bottom line is most of us need to do better, and if we look at how well we all do with our calculations in clinical practice, for example, the largest study that came out in 2018 said that 80% were accurate within about a half diopter of predicted, and it's certainly worse for complex eyes. Now, the best that I've seen actually comes from one of our speakers, and I helped Adi a little bit with his talk, but it really comes from Adi's work and his group in Israel. And that is 153 eyes, most with normal axial length. Using these 3 formulas, they got over 92% within a half diopter of target, which means that about 1 in 11 still is off, even with these really excellent results. And again, mostly normal axial length. And one of the points I want to make is this is probably the best we can achieve, can expect to achieve, considering all the sources of error. So when we measure, of course, we measure anterior corneal curvature, axial length, anterior chamber depth, lens thickness, corneal diameter. Some formulas are now including posterior corneal curvature, corneal thickness, and other formulas may factor in refraction, age, gender, and even ethnicity in trying to come up with the calculations. So what are the sources of error? The classic article by Spheriker Normy pointed out that it was ELP, axial length, in the time of ultrasonic measurements, and refraction. And why refraction? Well, because when we refract, there are errors in our refraction. Remember, only quarter diopter steps, and that can create at least the illusion, if not the actual measurement of error. So what are the sources of error today? Well, ELP is still there, and now the cornea has really assumed a very important role, both anterior and posterior, and again, refraction. Well, axial length is not on the list, of course, because we have optical biometry, which has gone from PCI to optical low coherence and now into swept source OCT with fabulous accuracy. So how do we calculate IOL power? Well, the classic formulas you see here are the sort of the Virgin's formula, where you enter the post-op refraction you desire, the average corneal power, the axial length. Each formula will have its own internal formula for calculating the effective lens position, and it spits out the IOL power that you then would implant in the patient and hope that you hit your target. But really, we have a huge array of formulas now, many of which are still based on this geometric optics, using 2 variables for the ELP, 5 variables in the Panacea formula that also includes the posterior anterior corneal ratio and the radius of curvature, which is interesting, the Barrett 5 variables, and the Holiday 2 that uses 7. There are ray tracing formulas, and we'll have the opportunity to hear Tom talk about his formula, which remains the leading ray tracing formula in use, obviously. And then there are artificial intelligence formulas, big data, as it were. The Hill RBF, now in its newest iteration, the Hill RBF3. The Pearl is also a big data formula that's kind of gaining some popularity from Damien Gottinel. And then finally, these combination formulas. And actually, you know, a lot of the formulas are really combination formulas, whether it's geometric optics and some regression or big data in order to figure out certain elements to adjust for axial lengths and so on. So formulas are kind of blending together in certain respects. What's ideally best? Well, Tom's approach is really the best because ray tracing incorporates all of our aberrations, the aberrations of the cornea, if there are significant ones, the aberrations of the IOL, anterior and posterior curvatures. So theoretically, that ought to be the best we can do. And we've also looked at measuring the eyes by the segments, looking from the aqueous as opposed to the lens, as opposed to the vitreous cavity. And that would enable us to really customize the measurement of axial length instead of measuring it with one unified, unique index of refraction. But our Barrett, at least with our data with the Barrett Universal 2, said there were some benefits, but really for eyes at the extreme, under 21 and over 31. And that tells me that Dr. Barrett's done a great job of kind of blending in other things for these long and short eyes. But the limitation that all our formulas face, and ray tracing among them, is the solution to the ELP quandary. Tom will talk about what he's come up with. But the data with ray tracing formulas still remain, although among our best, no better than our other best formulas, even though theoretically they should be. But I think they currently should have a special role for those eyes with irregular corneas, and they do great with long eyes. So can we improve our prediction of ELP? Well, there have been studies that have been using OCT on eyes preoperatively and intraoperatively to look at whether or not you can improve the ELP prediction, but none have shown better or more accurate IOL calculations, even though that the prediction is better. And unfortunately, as we all know, ELP shifts postoperatively. How many of us have seen that patient 20/20 on day 1 who comes back 20/30 on day 21 with now a -75 refraction? So it shifts, and it's unpredictably. In a paper by Nino Hernschall and Oliver Findel's group found that 17.6% of eyes had a shift in the anterior chamber depth of 1 millimeter or more from 1 hour measured postoperatively to 2 months. So we can put it where we think the right spot is, and it may shift as the eye heals and the capsule contracts. Short eyes are a bigger challenge, and the data we published found that actually among the formulas that we looked at, the Holiday 2 was a little bit better than the others, but statistically they were all comparable. And other studies have subsequently shown this also. Well, the reason for the poor outcome, of course, is the ELP problem. You've got a high-powered IOL with a small shift in this IOL can induce a large refractive change. So we're unfortunately not doing any better with the short eyes, and around maybe at best 80% most of the time. And that's something we need to warn our patients about. And one other point is Tom Olson and others have done some important papers looking at how you should compensate. If there's an error in one eye, how do you compensate when you change for the other eye? And his recommendation was about a half of the amount. If you're off by a diopter in the first, change it by a half. I think in these really short eyes, since anatomically they're unique but like each other, it's probably good to make the adjustment almost fully one eye to the other in order to be more accurate. So that 50% rule may not work in that subset of eyes. I've really stated that. So we're doing better with long eyes, and that's because of, well, we started the ball rolling of that with our modification of axial length, and we looked at recently at 1,600 eyes, and we got 93% within a half diopter. And also superb, though, and that are readily available and are the Hill RBF3, the Barrett Universal 2, the Olson formula, and the Kane all have reported good outcomes in long eyes. Why are we doing better? Well, you've got a low power IOL, so a small shift in the ELP has much less impact on the outcome. What about the post-LASIK eye? Well, multiple studies have been done, obviously, and the best data I've seen is one paper from Sam Maskett and Nicole Fram with the HIGUS-L and with the Maskett formula, with 85% within a half diopter. But if you look at the literature, almost all of the other reports are 75% or less, or even below that. And that's myopic LASIK. Hyperopic LASIK, the best data I've seen were one from a group in the Netherlands, 73% with a Barrett, True K, no history. Our results in post-hyperopic LASIK eyes were a very disappointing 57%. So what about this, the advances we now have in measuring posterior corneal power? Unfortunately, it hasn't really brought us the benefit we had hoped for. The IOL Master has total keratometry, which measures the front using the LEDs, and the total corneal power using the swept source OCT by measuring the posterior corneal curvature. And Graham Barrett reported his data with the IOL Master 700, still only 72% within a half diopter. Our data using the HIGUS formula, not the HIGUS-L, but using the HIGUS with total keratometry, again, still less than 70% within a half diopter. So we're still kind of frustrated with our post-LASIK eyes. It remains curiously a difficult problem to solve, presumably because of this variability in corneal power due to the postoperative change. Aura has been used, and again, it does take into account posterior cornea because it's literally performing a refraction on the aphakic eye on the operating room table. Our data actually showed that we did more poorly with Aura than with our preoperative calculations, but I should point out we do a lot of measuring preoperatively, including the Avante OCT, which has helped us improve our accuracy a bit. So Aura has not been helpful to us, and we've actually stopped using it. Aberrometry is helpful, however, for error prevention. And there was an example I can give in my own practice where the IOSCRS calculator predicted 23 diopters. The Aura recommended 24.5, and that caused me to do a lot of head scratching. And we went back and looked at the data in the operating room and found out that an incorrect value for the axial length had been inserted into the IOSCRS website. So anything you can do to prevent errors from occurring, and Aura is one of them, is certainly valuable. And I think the problem, of course, is that we're measuring these eyes using standard IOL calculation formulas after surgery's been performed, and it's a modified cornea, etc. And we're still trying to figure out where the ELP or where the lens is going to sit. and that doesn't have any magic on that because it's using the classic types of formulas. Keratoconus is an even bigger challenge. Data compiled by Sumitra Khandelwal in our group from 3 different groups, including a group from the Netherlands, Rudy Knight's group, with 70 eyes. You can see the error. This is the corneal power along the mean corneal power along the x-axis, and this is the hyperopic error. You can see as the steeper the cornea is, the greater the hyperopic error. This is the Holiday one, but it really was true with other formulas as well. And the R-squared was pretty good for the regression line here up to about 50 diopters, but above 50 diopters, the R-squared is very poor, indicating the huge scatter in the data. Now, we're fortunate to have some new keratoconus formulas out, the Kane and the Barrett, and hopefully they will give us some better outcomes, and that remains to be seen, of course. Well, that brings us back to what we can control today in our practices. Here's a patient of mine who came in to see me on the pre-op visit. Ks are 4334, astigmatism of 2 diopters against the rule. Didn't get any Ks with the IOL master. And I looked at the data, and there's a missing LED mire here down in this lower quadrant. This patient had seen me 3 months preoperatively, and the Ks were 44.6 with a Galilei, as opposed to the 4334 we got on the day of the pre-op visit. And you can see the mires from the Galilei, by the way, are very good. The astigmatism was 1/10 of a diopter with a Galilei, as opposed to the over 2 diopters we got with a Lenstar. Well, looking at the raw data from the Lenstar, you can see the missing mires in the same area that the IOL master was missing them. I looked at him, he had some dry spots on the cornea, so I treated the dryness. And actually only 6 days later, there's still a little bit of irregularity down there, but much, much better. You can see that all the mires are in fact in place. And I put an EDOF in this patient, and he was right on target, 20/20 J2. So corneal power is a major source of error. We need more than one measurement, and optimizing the cornea for your surgery is really critical. And all of my patients get a little handout that says, use warm compresses, use preservative-free tears, and use lid cleansers for the couple of weeks before surgery in order to try to really get their corneas in good shape. It's a lesson I learned from cases like this. And of course, you must verify the quality of your raw data. You can't just accept the numbers these devices give out. You have to look at standard deviations, you have to look at the LED mires, etc. Here's another example where the Lenstar gave me 27 millimeters for the right eye and 26.59. Of course, it gives you a warning signal. You can see there's a high standard deviation, which is higher than what we would expect of 0.02 millimeters, and fairly consistent, but these funny readings. The IOL Master 700, on the other hand, gave 2693, which is pretty close to the right eye. So we repeated the measurement in the Lenstar and got 2691, and the problem was that the measurement had been done with the optical head too close to the eye. So there are lots of ways you can have errors, and you need to really be attentive to your raw data. And we have validation criteria that we use. We confirm the measurement mode for the biometer, axial lengths within 0.2, the standard deviation 0.02, and then 2.5 to 4.5 for the ACD, and 4 to 4.5 for lens thickness. Well, what about postoperative modification of IOL power? You've had it a lot longer in Europe than we have. Is it going to be useful for everybody? I think probably it's going to be more isolated for the outlier eyes, because we're doing so much better with our formulas. We have the RX site approved, and of course these other technologies are being developed. So a final word, we had one of the articles published in the January JCRS was with Jack Holliday and myself and others, Lee Wong, and we have found that you need to actually analyze your IOL calculation outcomes using just the standard deviation. And that's the single best parameter to characterize the performance of an IOL calculation formula. And I think we're going to see a shift from mean absolute and median absolute errors to using good old-fashioned standard deviations. And with that, thanks for your attention, and I'll stop.
Doug, thank you very much. That was tremendous, a real tour de force from someone who's been there and done that and got the scars on their back. We're going to have some questions at the end. So everybody who wants to put questions, can you please put your questions into the Q&A and we'll do it all at the end. But I've just got one question. You talked a lot about effective lens position. How much do you think the tilt and the sort of lateral translocation and sideways movement of an IOL within its effective position after surgery has an effect?
Well, you know, there is definitely lens IOL tilt, and we've looked at the relationship between the crystalline lens tilt and the IOL tilt. And to be more clear, the IOL is tilted so that the nasal part is anterior and the temporal part is posterior. And it can be on average about 5 degrees, which doesn't do much in terms of IOL power. But if you're one of those eyes that has a 10-degree tilt, it actually can have quite an effect on toricity. But a tilted IOL that's decentered a little bit, Paul, to your point, probably will impact the ELP, and we haven't gotten anywhere near figuring that out because we don't have a way yet to calculate IOL tilt. None of the devices give us IOL tilt, so we're kind of stuck there. It's a good question.
Well, thank you very much. So, Doug, thank you very much. We're now going to move over to Adi Abilafia. Everybody, Adi is an ophthalmologist who's a consultant in Jerusalem. He's head of the cataract service there, and he's president of our sister organization, the Israeli Cataract Society. So it's an absolute delight to introduce Adi to you. And Adi's going to continue the theme, talking more about lens calculations, a little bit more about toricity. Adi, over to you.
Okay, so thank you so much for inviting me and for the kind introduction. It's a really great honor to be here. So I'm going to talk today about correcting astigmatism. So my financial disclosure can be seen at the bottom of the slide. And so corneal astigmatism is a common condition. And if we look at the large database, it shows that more than half of the eyes have 0.75 diopters of total corneal astigmatism or more. So actually the amount of cataract patients that might benefit from astigmatism correction is huge. And toric IOLs are gradually becoming the standard of care for these patients. But as we all know, the refractive results following their implantations are not always predictable. So this evening, I would like to share with you 8 tips for improving your toric IOL outcomes. So the first tip is to validate your data and to look at the corneal topography. And this was covered beautifully by Doug. So data validation is the fundamental requirement for accurate measurements. So make it a common practice to look at the raw data and to evaluate the actual quality of your measurements. And it's important to perform corneal topography for these patients to verify that the Meyer rings looks okay and that we are dealing with symmetric and regular astigmatism. Now, the next step is to diagnose and to treat any pre-existing ocular surface disorders, since corneal measurements in these eyes might be unreliable. So let's look at these 3 examples. So here is corneal topographies of a patient with dry eyes before and after a course of steroid drops and artificial tears. And this is a patient with map dot fingerprint dystrophy before and after superficial keratectomy. And another patient before and after pterygium removal. So let's move to the next tip, and the next tip is to use several measuring devices. So there are many devices using different technologies to measure the corneal astigmatism. And when we use several measuring devices, it might keep us safe in case that one device will get it wrong. So my advice to you is, if possible, use at least 3 measuring devices for this task. But however, measurements by 3 or more devices will typically produce 3 or more different values. So now you need to decide which values to use. Now you can either use your own clinical judgment, or another and easier alternative is to use a software that will automatically generate it for you, such as the K-Calculator feature on the Barrett Online Toric Calculator. Now moving to the next tip is to take into account the posterior corneal astigmatism. And today it's a common knowledge that standard keratometry and topography machines tend to yield inaccurate results in assessing the total corneal astigmatic power. What they do, they measure the anterior corneal curvature, and they assume that there is a fixed ratio between the anterior and the posterior surfaces of the cornea, which we know is not correct, mainly thanks to Doug. So we know that most of the posterior corneas are steep along the vertical meridian, And we also know that the posterior cornea acts like a minus lens. So it will produce a positive refractive astigmatism effect along the horizontal meridian. Now, in order to make our life more simple, we tend to say that it reduces the total corneal astigmatism in eyes with with the rule astigmatism and increases it in eyes with against the rule astigmatism. But the reality is slightly more complex than that, because both the anterior and the posterior surfaces of the cornea contribute to the total corneal astigmatism power, which has its own magnitude and own meridian. Now, ignoring the posterior corneal astigmatism effect will typically lead to against the rule errors in the predicted refractive astigmatism. And basically, two approaches have been taken to address this issue. The first, improved mathematical methods that are based on anterior corneal measurements, and the ultimate goal, direct measurements of the posterior cornea. So here you can see again the against the rule prediction errors using standard anterior corneal measurements. And this is how it looks after applying a mathematical model. Now, many of us use mathematical models in our daily practice. Some are fully integrated, like the Barrett with a toric calculator, while others are available as an on and off option. But the problem with mathematical approaches for selecting toric IOLs is scatter, since there's a wide individual variation even in so-called normal corneas. So ideally, we should measure the posterior cornea directly. But if we look at the current literature, it seems that mathematical models are more accurate as compared to direct measurements of the total corneal astigmatic power. And even intraoperative aberrometry seems to be no better than the mathematical models. So why is it so hard to measure the posterior cornea? Well, the small difference in the refractive index between the posterior cornea and the aqueous makes it a tough surface to identify and to quantify. And there's really no gold standard to validate our measurements. But can it be that there is another reason why the mathematical models outperform direct measurements? Well, one possible explanation is that many of the mathematical models do not account only for the posterior corneal astigmatism effect. Rather, most of them are designed to account for the differences between the anterior-based corneal measurements and the post-op refraction. So they might include other factors affecting the refractive outcome. Factors such as physiological IOL tilt or decentration. So let's look under the hood of one of the mathematical models, the Abulafia-Koch formula. Now, it was designed as an add-on feature for standard toric calculators in order to compensate for the differences between the anterior corneal astigmatism and the total astigmatism of the pseudophakic eye. It is based on two separate linear regressions for calculating the X and Y components of the estimated total astigmatism using anterior corneal measurements. And as you can notice, the correlations for these two components were extremely high. And here you can see three examples for the preoperative anterior corneal astigmatism and the estimated astigmatism that should be corrected for each eye by the Abulafia-Koch formula. Now, as you can notice, both the magnitude and the meridian values are adjusted by the formula. And now that you know how mathematical models work, you can easily understand why one should never use standard mathematical models with total corneal measurements. And this is because you are going to account for the same problem twice and you are going to get it wrong. Now, the next tip is to be alert for the unusual corneas. Now, unusual corneas like keratoconus, post-refractive eyes might present unusual ratio between the anterior and the posterior corneal surfaces. However, standard mathematical models are not designed to account for that. So the best available solution for these patients might be either to use total corneal measurements with standard toric calculators, or another alternative is to use the Barrett toric calculator with direct measurements of the posterior cornea. And for post-refractive eyes, you can use the Barrett-Ruquet toric calculator, which incorporates a specific mathematical model for these corneas. This was covered by Doug as well. Now, it is worth mentioning that recently a mathematical model was added for the post-refractive eyes in the EVO toric calculator, and that a mathematical model for eyes with keratoconus was added for the Kane toric calculator. Now, what about the corneal SIA? Should we use a fixed ratio for our corneal SIA? So should we use 0.5, 0.25, maybe 0? Or should we calculate our own personal corneal SIA? And the answer to these questions is not so simple as one might think. Now, in order to perform an ideal personal corneal SIA calculation, one should use consistent location and wound architecture for the main incision, to use measuring devices with high repeatability and accuracy, to use centroid value for the analysis, and to have a long-term follow-up. And ideally, we should perform an additional subgroup analysis in order to estimate the effect of the incision location proximity to the steep meridian and for different magnitudes of corneal astigmatism. And this is quite a tedious task. Now, here you can see my personal corneal SIA values with the Lenstar device. They came out as 0.07 diopters for the right eyes and 0.08 for the left eyes. Now, I did a repeated analysis for the same eyes, but using the IOL Master 700, and it came out very similar. And the same goes for the total keratometry. Now, the best way, I think, is to calculate your own SIA, but as I mentioned before, this is quite tedious and not always possible or feasible in all the clinical practices. So I think that a reasonable compromise would be to use consistent corneal incisions with low corneal SIA values, somewhere between 0 and 0.2 diopters. So moving to the next tip is to have a low threshold for performing toric IOL calculations. Now, in our daily practice, we are used to look at the spherical equivalent prediction given by each formula for a given IOL, but ideal printout should include complete predicted refraction. And some biometers have this option, but usually it comes only for the toric IOLs. So let's have a look at this example. This patient has about 0.6 diopters of against the rule corneal astigmatism. Now, instead of beating our heads trying to figure out whether this patient would benefit from a toric IOL implantation, you can simply use a modern toric calculator to look what would be the predicted post-op residual astigmatism for a non-toric IOL. Now, in this case, the patient will probably end up with about 1 diopter of residual refractive astigmatism, and this information can help you to decide whether you would prefer to implant a toric IOL or not. Now, the last tip is to optimize your toric IOL alignment. So we all know that proper toric IOL alignment is important for optimizing our post-op refractions. And though most of us use manual reference marking, which are quite accurate, it seems like computer-assisted marking have a small advantage over manual marking. And one elegant and potentially even more accurate alternative is to use a femtolaser to create permanent capsular axis landmarks. And this is how it looks. Now, each one should try and to find out his own preferred technique in order to achieve consistent toric IOL alignment. But no matter which technique you use, I urge you to meticulously aspirate the OVD behind the toric lens in order to reduce the chance for post-op IOL rotation. So these were my 8 tips for improving your toric IOL outcomes, and I hope that you will find them useful. Thank you very much.
Adi, that was really useful. I found that really a very in-depth and very deep understanding of all that. Can you just what effect do you think age has on the SIA? You know, older corneas react differently to younger corneas. Do you think that has an effect?
Well, it might have, and I don't have a good answer for that. I can tell you that I tried on my own data set to find a correlation between the SIA and age, and I didn't find one. But it doesn't mean that somebody else can, somebody else can find it, but I couldn't find it.
Okay, that's great. Okay, well, thank you very much, Eddie. That's a really good. We'll have some more questions at the end. We'll now go on to our third speaker, Professor Olsen. You've heard the Olsen formula being mentioned. Thomas Olsen is a professor in Denmark, created the Olsen formula, and I think that there's no better person really to take us through it and explain why it's such a good formula. So Thomas, over to you.
And thank you very much for the invitation. So these are my financial disclosures. I have been working in this field for some years, and I have some financial interest as well. I want to take you through these steps, just a short history of IOL power calculation. I know you had a lot of information from Doc already, but no harm done to view it once again. You know, we have more than 50 years of IOL power calculation formulas out there. And you know that it all started with theoretic formulas based on optical principles, but soon after that we had the regression formulas because they seemed to be better. And then we had improved thin lens formulas, and now we have improved biometry and we have better ELP predictions, but we're still not finished whether we should choose optical based formulas or we should choose regression or statistical formulas. Well, that's interesting to see. And you have to realize that many formulas, they use a kind of black box mechanism to find the secrets of their formula. That also goes for optical formulas. You need to find the ELP, and many thin lens formulas do it that way, that they back calculate the ELP to get the ELP as a function of a lot of predictors. But if you go to more higher sophisticated statistical methods, you can find the same procedure in artificial intelligence as well. So the battle goes on. There's an optical and there's a statistical approach. We also have the geography. And I don't think that we beat each other, but it's nice to have some competition. So I'll take you out of the black box and we'll discuss some of the fundamentals. And what are the fundamentals? Well, if you look at the formula of a thin lens formula, it's very simple actually. And it's based on the divergence principle, that you have the divergence at the back of the lens and your divergence in front of the lens. And by subtraction, you get the emmetropic IOL power. That's it. But there are a number of questions. What is the true axial length? That was the problem in the old days when we did the ultrasound. I think it's less a problem today because optical biometry is so accurate. But we're still left with the question, what is the true corneal power? And neither the cornea nor the IOL are thin lenses, so the optics will break down if we apply more sophisticated thick lens theory. And finally, how can we predict the ELP? And that's a very good question. The corneal power, what is it actually? Well, you know, if you take a K reading, what are you doing? You're not measuring the power, you're actually measuring the radius. And most keratometers, they are calibrated with this index of calibration. So if you take the anterior surface and you think the cornea is a thin lens, you get this power from the index of refraction. Actually, it means a 10 millimeter radius is the same as 37.5 diopters. But if you look at the thick lens situation of the cornea, you have the front power, you have the back power, and if you combine these, you get another number for the index of refraction. This was actually my entry into this world. As a student, I published this work because we had a lower index of refraction that might reflect reality better. But nowadays we can do more than just theory. We have ray tracing technology. And as you know, many newer techniques can give you a lot of 3D data, elevation map, matrices, and all that. This is an example of the Scheinflug, the Pentacam machine that will export these kind of data. You have the height, elevation there in all of the areas. This is the elevation data in microns. So you can actually shape the entire shape of the cornea, both on the front and also on the back surface of the cornea. And why not do a ray tracing of this surface? There are technologies out there that can be used for this job. And this is an example of the real Pentacam data of patients I have imported into the CMAX engineering software. And here you have the front surface of the cornea. This is the back surface and all the triangles that we combine to make a physical shape for which we can do exact ray tracing. And if we do that, we can also put in a pupil and then we can analyze where is the focus. What is the focus? Well, a focus is the point where you have the highest point spread function or the least blur. So if you do that and go for the distance giving the least blur, you have actually the power of that cornea. And we have done that in a number of patients here. This is a ray traced cornea power. And here you have the other metrics. The black dots, that's a K reading if you use the wrong index, I told you. And also the total corneal refractive power, which is given to you by the Pentacam, is in the middle. And actually the total corneal refractive power is claimed to be ray traced based, and it actually fits very well to our data from exact ray tracing on the cornea. So my point is actually, before we put any formula together, we must make sure the corneal power is right. Otherwise, we don't have the physical reality. So the most critical unknown is actually the IOL position. I prefer to talk about the IOL position because the ELP is such a virtual distance, it's not always reflecting the physical distance in the eye. But if we try to focus on the real position, first of all, that's just the ELP of a thin lens formula you're seeing here, and you have the old formula out there. And that's the distance from the corneal surface to the effective lens plane. There are a number of formulas out there, and they have all their own method of predicting the ELP. You can see also the time scale is going down here. We started with the K rating by the Fjorov formula in 1967. The Binkos were using the action length, that's the only ELP predictor. And then we have the SRKT combining the action length and the K rating. Actually, they copied some of the Fjorov approach. And you go down the list, and if we go down to the Heikis formula doesn't use the K for the ELP prediction. And that's very important if you talk about the post-LASIK cases, for instance. And of course, as Doc always mentioned, the Holiday 2 uses additional parameters like the refraction, white to white, gender, age, and many others maybe. My own proposal is to use another approach. I've always liked to use the physical distances and not just talk about the virtual distances. And this is how we did it. And it all came because the LensStar came out. And you know the LensStar can measure an A scan of the eye, just like the old ultrasound technique. But also after surgery, you can actually measure where is the IOL located in the eye. So this is very important. And we have been doing that for many years. And here you see a series of 1,622 cases where I have the IOL position. That's the center of the IOL here. We plot it against the axial length so you can see the dependence. The blue dots, that's the anterior capsule, pre-op, or the ACD. And the green dots, that's the posterior capsule of the lens. So the distance from this line to this line, that's actually lens thickness. As you can see, the IOL center is located within the lens. No wonder. I put it there when I did the surgery. But the trick is there's a mathematical relationship. And this is what I call the seek constant. The seek constant is very simple because it depends only on the ACD, pre-op, and the lens thickness. And here you can see the formula. By a fraction of the lens thickness, we add to the anterior chamber depth, then we get the center of the IOL after surgery. It's very important to realize that this constant is not depending on the K reading nor the action length, and it's going to play an important role when you go to the post-LASIK cases of very odd corneas. And you can also confirm the principle if you do modern OCT technique. This is a pre-op scan of a patient that has a post-op scan like that. That is the IOL situated there. And if you superimpose both images, you can see there's the IOL. And actually, if you measure from here to here, you will find it's about 40% of the crystalline lens thickness. And that's a very typical number for the C constant. So going back to the sources of error, well, the situation has changed since we got the optical biometry. Then the actual length is minimizing, in its size. So we don't have very high error from the actual length measurements, but the ELP or the IOL position is counting much more in a relative sense. Maybe we should concentrate more on the K rating, like Adi would say. This is maybe the new frontier. But the most important source of error is, no doubt, the lens position. What about the clinical results? Well, there have been some papers out there comparing the Olsen formula to some of the other formulas. This is a work by Cook and Cook from 2016, comparing up to 9 lens power calculations. And the Olsen formula came out quite good on the top, together with the Barrett formula. And also, as Doc mentions, we have a huge series from the Kaiser Permanente company. And this is published in Ophthalmology 2018. They had more than 18,000 cases, all done with the LensStar biometer. And in both, this was the original paper, and then we had an update because newer formulas were coming. And as you can see, the best formulas in the update publication, that was the Kane, that's a new formula from Australia, and the Olsen and the Barrett, all achieving more than 80% within half a diopter in a routine cataract series, I have to note. So I had the opportunity to analyze the material from Ron Mellers, and here you can see my comparison of the formulas. There's no doubt that the old thin lens formulas are not doing as good as we want it to be today. And in this case, I was down to 0.3 in the mean absolute error. That's about 0.4 something standard deviation. And also, if we count the number of cases within a half a diopter, you can see we are below 75 with some of the old formulas. And then we go up, the Hill RPF is 77 or something like that. The Barrett and the Olsen were about 80%. If we plot the error along the actual length, you can see that we are actually doing quite good in the long eyes. So we are out of those old days where we had high errors in the long eyes. Actually, the accuracy in this material was the highest for the very long eye. We still have problems in the short eyes, and it's got to be that way because the short eyes have smaller dimensions and every error counts more. So what about the future? This is very interesting. And I don't know about it, but one thing we could do is try extrapolating. And I do have some experience. I've been in this field for more than 30 years. And I looked through all the publications that I have made and to get the error in each publication. Here you can see the error as a standard deviation or the mean absolute error. It has dropped quite significantly when we started back in the 80s and 90s. And the reason why we are having better accuracy today is, of course, we have the optical biometry in around 2000. And 10 years later, we got the LensStar biometry that allowed us to do a more elaborate analysis of the ELP prediction. Another way of putting it is to count the number of cases within a half diopter. And Doc, as you can see here, now in my own series, we are better than 90% within a half a diopter. So in 5 years, we have more than 100%. How about that? So in conclusion, I would like to say that my approach has always been to divide and conquer the unknowns. We should pay attention to the measurements and the physical reality. And this is how we can get methods to predict the IOL position. I really believe it is possible to predict the physical position. And then we have, the rest is just optics, if you allow me to say that. So if we have these methods, we can do accurate and unbiased calculations, and we don't need any magic. And this is my point. Thank you so much.
Thomas, thank you very much. That was just, again, just a tour de force, and it summarized so well everything that the other speakers have spoken about. And I was just thinking, and it's amazing. It's not often I've sat to a lot of lectures to hear someone who quotes their own research that they published 35 years ago, who's still relevant to the same subject is amazing. And it's a real testament to you. Can you just, I was very interested about your the C constant you created for the effective lens position. Can you just explain a little bit more about how you arrived at that?
Well, by measuring, I have always been interested in knowing the exact physical position of the lens. And back in the old days, we were doing that by ultrasound. So I did have some experience, but that was not very accurate. So it came to me that the lens start biometer with its laser technology is so much more accurate. So now you can rely on the measurements. As you know, you can even measure the thickness of the IOL if you want. And by that way, you have a method of calculating the power of the lens inside the eye, by the way. But anyway, I have been concentrated on this job for many years. And I have been all the way also back calculating the effective lens position. And I just want to point out again, the effective lens position, that's depending on some formula. The effective lens position is that distance that works in that formula. So it's not the physical. And this is important to make the distinction. So I've been chasing the physical position of the IOL. There's no other way to get it than to measure it. And that's how we did it.
Thank you very much. I'm now going to hand over to Sarge, who's going to hit back with some more questions. Over to you, Sarge.
I am. I'm just going to ask a question from myself to Thomas first. So, Thomas, for your C constant calculation, are you assuming that when the lens, when we remove the lens, we put the artificial lens in, that the zonules are acting on the center of the capsular bag? Yeah. So thereby, you're saying that you're essentially assuming that it's going to end up halfway through the lens.
Well, I'm not assuming anything. I'm measuring it.
Right.
So the statistics will show that you may be quite right, that it tends to locate itself quite near to the center, actually. But as I told you, the number of the C constant is not 50%. It's more like 40%. So it's not totally depending on the plane of the crystalline lens. There will be some anatomic features to account for, and you can name a lot of reasons why it shouldn't work, but my point is it does.
Yeah, no, which I think is great, but it reinforces the fact that there is, despite it being different individuals, there is more uniformity than you would expect with human variation.
Exactly.
Could I ask a question?
Sure.
Tom, I loved your talk. Your 90%, was that with one IOL? And I guess my question is, does the C constant vary from different IOL types? And have you refined it so you have a different C constant for each IOL? And then the second question is, if you're hitting over 90%, is that using the Pentacam and doing the kind of Zmax work that you described, or is that using? And the third part of that is that the lens, the same Olsen formula that we have available to us today in the LensStar?
Oh, that was 3 questions, right?
Yep.
But anyway, my own series, that was not just one type of IOL. There were 3 or 4 types I use. I do a lot of multifocal implants and toric implants, so it was a mixture. And for your second question, yes, you're quite right. The C constant is much like an A constant, because you need to have different constants depending on the haptics, the angulation, and what is the optic configuration, whether it's 1:2 or 1:1 or 2:1, biconvex type. So all these factors will account for some differences in the C constant. But having said so, I find it quite fascinating that the difference between one IOL type to another is not very big if you look at the C constants. So there will be a uniform principle here to work on, I believe. And finally, for the corneal power, now these cases were routine cases, and I don't do the CMAX on a routine case. It takes about 10 minutes for me to do one cornea with the CMAX. Having said so, we also have a customized ray tracing technology that we can use for the odd corneas, like the post-LASIK. I didn't cover the post-LASIK corneas here, but it's obvious one area of interest for my formula because it's not depending, the ELP prediction is not depending on the K reading or the corneal power. So we can do more sophisticated analysis if you want for those specialized.
And is your formula that you're talking about the same one that's in the LensStar, or do we need to use
That was the last question. Yes, we had some differences, like the work by Cook and Cook was showing that the LensStar version, the first version, was actually doing a little worse, a little worse than the standalone software version that I have been producing on the web for some years. Maybe due to some intrinsic statistical correlations that we can use to refine the seed content. I'm not saying the seed content is just a constant. It may also depend on the action length just a bit and a little on other factors. But the core of the principle is still the seed constant, and then you can add some covariance to refine the method. And that's what the version coming out now, the newer LensStar version, that's the same version as the standalone software version.
Great, thank you.
Thank you, guys. We've got a few interesting questions coming forwards. So, Adi, question for you. Most toric calculators would change the axis of astigmatism if you enter a modest SIA value. Do you think the new axis might be misleading? So should you stick with your alignment with the original axis before you put in your SIA, or factor that in?
Yeah, well, this is a good question, but I think that the effect will depend on the differences between the vector of the astigmatism and the vector of the SIA. Now, if you saw in my talk, my SIA was about 0.1 diopter. So it will almost not affect the total power that you need to correct, but I do put the 0.1 at the moment. I do put my calculated SIA and I go with that.
I think that's why the question was specifically about putting, it was described as a modest SIA, but if you start going up to 0.4, 0.5.
Yeah, well, I wouldn't suggest to put these values.
Right.
Just if you don't calculate your own SIA, I would suggest to use 0.1.
Right. Okay.
And then the effect will be minimal.
And is that also because we expect some degree of SIA regression with time?
Well, this is another good question because my data was 1 month post-op. So it might be that if you look 3 months or 6 months afterwards, there will be no effect at all. But this needs to be studied.
I guess as cataract surgeons, that's what we'd all like to think, is that we don't alter it at all. But yeah, no, it'd be interesting to know. So, a question for the whole panel from David Spalton. Do you feel that we should leave some against the rule astigmatism to increase depth of focus for near vision?
Well, I'm happy to tackle that because I've actually advocated the opposite. I understand David's theory because against the rule of astigmatism for Arabic numerals and letters, because of their more vertical components to them, gives you better depth of focus for reading. On the other hand, we know that there's about a 3/8 of a diopter shift against the rule in most eyes over time. And therefore, I like to leave patients a little bit with the rule if I'm really trying to correct their astigmatism, so that maybe a 1/4 diopter, and that way they'll benefit from the correction of the toric of their astigmatism for a longer period of time, particularly if you're going to use a multifocal or any kind of extended depth of focus lens. So you can argue both ways, but I always leave them a little bit with the rule.
And so on that principle, would you adjust that according to age of patient?
That's a good question, but I don't. And I mean, you could argue that you should leave the 50-year-old with one diopter against the rule. Well, the 50-year-old's not going to be very happy with me if I leave them with one diopter with the rule. So I do the same for everybody, even though the 50-year-old may need something tweaked in 20 years.
Thank you. Another more generalized question. Feeling of the panel with regards to whether cataract surgery should be done by specialist cataract surgeons, much as glaucoma has moved from the general ophthalmologist to being specialist glaucoma surgeons. Do we feel that would improve our outcomes?
A good cataract surgeon is a good cataract surgeon. And there are many comprehensive ophthalmologists that do beautiful cataract surgery. So I don't think you should be doing one every other week. I think you need to have a certain volume in order to feel comfortable in the operating room. I'm a little rusty if I haven't operated for 2 or 3 weeks. So I think a certain volume is reasonable. What that volume is will depend. I think it's probably at least 3, 4, 5 a week.
Yeah. And nice to hear you also get rusty after a short period. Going back after lockdown was horrible. That was 5.5 months worth. So.
Right, exactly.
There are people who advocate the use of CTRs for big or abnormal eyes. So this will be aimed at you, Thomas. Is there any evidence on its effect on IOL position?
I know nothing about that. I know it's common to use it, but I'm not sure of the effect on the refraction outcome. I'm sorry, I don't believe it actually, because the CTR is also depending on the anatomy of the crystalline lens, that maybe it just fits in the same plane. So I have no specific answer to that.
And
I'm aware of one paper on that showed no change. That supports what Tom says.
Yeah. So expanding on that question, Addy, there are people who query putting a CTR in when you're using a toric lens in case it reduces the adhesion of the bag and allows more rotation. Any feelings or an experience of that?
Well, I don't do that. I don't put CTRs on a daily basis for toric lenses. And I'm not sure what would be the effect, or if somebody really took two groups and examined that, because it will stretch the bag in one side, so it might rotate more, but it reduces the volume of the bag. So I don't really know what is the effect of a CTR on the stability of a toric IOL.
Yeah, thank you.
Maybe Doug has a better idea.
I put them, if I think the bag is huge, I may put one in, and particularly if I'm orienting the toric lens vertically. But like Adi, I'm aware of no data that justifies that.
Yeah. Thank you. So we have a general question in terms of personal preference from all three of you with regards to dealing with post-LASIK eyes and your personal preferred formulae. If I, just purely because you're top on my screen, Thomas, if I ask you first.
Could you repeat the question, please?
What formulae do you use for post-refractive eyes?
Oh, well, I use my own formula. I'm sorry to say that, but since I have divided the issues on the ELP prediction on one side, then I can treat the corneal power as it is really. So if I have a post-LASIK case, I like to do the pentacam. If I have the Galilei, I do that as well. And then I do the analysis of the true corneal power. And I showed you in one of my slides that actually the pentacam-derived TCRP is very similar to my own ray-traced corneal power value. So if I don't have the time to do the exact ray tracing, I take this TCRP value and put it into my formula. And since it will take the real physical value of the power, I can make good predictions, I would say. I have very little experience with some of the other formulas, but I like the Barrett. I don't think the Heikis is doing very good. actually. So I'm not the one to ask about different formulas.
Doug, your opinion, please.
I use the Barrett. I like the Barrett. I like the OCT-based formula that we helped David Wong develop. I still use the Hygas as a sort of a check, and I still use the Shamus in our own formula as a check. But the two that I rely upon the most, in the absence of having Tom's wonderful ray tracing, I would use that definitely if I had it, because I think that's the way to go. I use the Barrett and the OCT.
Right. Well, you almost supported my own practice with the Barrett, but I like the backup of the UKISCRS. So thank you for reinforcing that for me. And Adi, for yourself.
Well, I would echo Doug saying that if I had the opportunity, I would use the Olsen way of how he does it. But I rely heavily on the Barrett with the measured posterior cornea. But I do look at some other formulas as well, and I try to figure out what would be the worst case scenario. Sorry, so to have like some boundary to be safe, and not to go to the hyperopic side.
Thank you. So final question, I think, is probably towards you again, Adi. If you have a significant difference in refractive and keratometric astigmatism with good scans and a normal lens, do you make any adjustments to prevent ocular residual astigmatism? I guess this is bringing in the posterior corneal astigmatism element.
Yes, but the thing is that you shouldn't rely, unless it's keratoconus or that you have old glasses prescription, but I usually don't look at the refractive data so much because it can come out of the lens as well. You have to remember that. So if you have a solid measurements of the cornea, I would just go with the calculation, regardless of this discrepancy.
Thank you. And again, thank you for reinforcing that. That's what I would have said. Amazing presentations, gentlemen. Those are the last of the questions. I shall hand back to Paul, but I feel enlightened and reassured by all three of you, so thank you.
Yeah, there's not much more I can say. That was fantastic. That was a really, really amazing presentation, set of presentations. All three of you did really well. I just couldn't begin to say thank you enough. So thank you from me, and I'm going to now hand back to Satish, who's going to close.
Yeah. Thanks, Paul. And once again, thanks to Doug, Tom, and Adi for being very generous with your time and for sharing the wealth of knowledge. I think it's one of the important takeaways for me is, although we have made huge strides towards emmetropia and towards achieving 100%, I think from Doug's eloquent data presentation, we have seen that we are still hovering around the 85 to 90% mark. I think this is very important that when we consent and counsel our patients, I think this message has to be very, very clear so that we can really set the expectations for our patients and then make them aware that this is still an art and not total science. I think we are well past the time. It's 7:44 now. Once again, I thank all of the speakers, especially Doug, for stepping out of his busy clinic in Houston at the moment for doing this. And once again, I would like to thank all our industry sponsors, Hackstraight, Thea, and Scope for being very generous with their contributions to help this going. UKISCRS will continue to provide virtual education on a monthly basis till the time we are able to meet face-to-face. The next webinar is scheduled for the 4th of March. This will be read by our council member, Rizwana Khan from Dublin. The theme is going to be on ocular surface and oculoplastics. We'll be sending more information in due course time. I think with that statement, I would thank once again for all the participants for tuning in for this evening. And I will ask the council members to stay back or in fact, join back for the council meeting with a different Zoom link. Thanks everybody and stay safe. Good night.
Thank you, Satish. Thank you, Paul. Thank you, faculty. Thank you to all the participants, still have 130. Please do remain if you'd like to see any of the slides and the full details of the programme for the 4th of March, which will be on the following slide too. Registration is open on our website for the 4th of March, as is our new donate button, which, as I said at the beginning, as UKISCRS are now a charity, and until we're able to meet again face to face, it is greatly received if you'd like to support us so that we can continue to provide this online digital education. I thank all of the council, and as I say, thank you to the industry and delegates for joining. It's been a great first webinar in 2021, and I hope to see you all properly very soon. Take care, keep safe, and good night.